When we talk about architecture and engineering, we usually picture these really rigid structures.
Right, yeah, like steel beams or, concrete pillars.
Exactly. Materials where the rules of physics are just highly predictable. You build a suspension bridge, and you can calculate exactly how much tension those steel cables can handle before they fail.
Solid mechanics are incredibly comforting that way.
Yeah.
The math is straightforward, and the materials don't just, suddenly change their fundamental nature just because you put pressure on them.
But imagine a completely different kind of engineering challenge for a second. Imagine trying to build a structural support system out of a liquid.
Wow, yeah, that's a completely different ballgame.
Right. You need a fluid that can flow effortlessly through this microscopic pipe, but the moment it reaches its destination, it somehow has to, remember that it's supposed to act like a solid, weight-bearing brick.
Which pretty much defies the basic rules of how matter should behave.
Yeah.
I mean, you're talking about a fluid that essentially has a memory and a programmable structure. It's a total structural engineering paradox.
And welcome to this deep dive where today we are exploring exactly that paradox, which happens to be the foundation of a modern medical miracle.
It really is.
If you are joining us, you likely already follow the fast-paced world of aesthetic medicine, so you know the basics of dermal fillers. But our mission today is to go far beyond the surface. We are answering a surprisingly complex biomechanical question.
And it's a very specific one, too.
Very specific. We want to know what extrusion force and rheological properties are actually required when injecting soft hyaluronic acid dermal gels through a tiny 22-gauge or 25-gauge cannula, specifically into labial fat pads.
And answering that specific question really reveals the sheer physics and bioengineering behind treatments that, frankly, people outside the field often just dismiss as cosmetic.
Right, they think it's just about looks.
Exactly. Facial fillers might get all the mainstream attention, but off-label and specialized applications like labial augmentation reveal the absolute precision required of this science. I mean, the margins for error in these soft dynamic tissues are virtually zero.
Yeah, and to map this out for you, we are synthesizing a massive stack of clinical data today. We're looking at abstracts from the FACE conference, comprehensive rheological evaluations of advanced HA fillers like Meili, Regenoview, and Bellatero.
All top-tier products, yeah.
And we are also pulling from highly specific studies on female genital mucosal and labia majora augmentation, focusing heavily on products like the cereal.
And just to add to that, the clinical data here doesn't just look at, before and after photos. We are diving into the actual molecular cross-linking bonds, the behavior of fluids under mechanical stress, and these in vitro syringe extrusion tests that are measured in exact newtons of force.
So if you are a medical professional refining your technique, or maybe an aesthetics enthusiast tracking the latest science, or honestly just someone who is insanely curious about the physics of non-Newtonian fluids, this deep dive is going to completely change how you view a simple syringe.
It definitely will.
Okay, let's unpack this. Before we can even talk about getting a gel into a specific anatomical target, we have to look at how these biogels are engineered to basically exist in two states of matter at once.
Yeah, that dual existence is the core of rheology, which is the study of how matter flows and deforms. When we look at hyaluronic acid fillers or HA fillers, we are dealing with viscoelastic materials.
Viscoelasticity. I always try to visualize this by thinking about the extreme ends of a spectrum.
That's a good way to do it.
Like on one side, we have pure elasticity, like a heavy-duty shock absorber or memory foam. You compress it, it deforms to take the weight, but the moment you release the pressure, it just bounces right back to its original shape.
Right, because it stores the energy of the deformation. That's a crucial concept here, that's stored energy.
Then on the other extreme, you have pure viscosity. Think of like motor oil or honey. If you pour it onto a flat surface, it spreads out endlessly.
Yeah, it loses its shape forever. The energy is just lost, dissipated right into the environment.
And that highlights the massive bioengineering challenge for these manufacturers. If a labial filler is purely elastic, like a dense block of memory foam, it would be far too hard.
Oh, absolutely. You literally wouldn't be able to push it through a narrow syringe, let alone integrate it naturally into soft human tissue.
But if it's purely viscous, like honey, it's just too liquid. It would spread out under the mucosal tissue and completely fail to restore any actual structural volume.
Exactly. So it needs to be the perfect hybrid of both.
So when we look at the clinical data for these gels, they measure this hybrid nature using a few specific metrics. I see Complex viscosity mentioned a lot, which makes sense. That's the resistance to flow, basically the gel's overall thickness.
Right.
But the sources focus really heavily on something called the elastic modulus, or G prime, and tan delta. How do scientists actually quantify the difference between the honey and the memory foam within a single gel?
Well, G prime is essentially the mathematical measurement of that memory foam property you mentioned. It measures the energy stored in the material.
Okay, so a higher G prime means what exactly?
In the clinical world, a high G prime translates to firmness and lift capacity. It's the gel's ability to hold its shape against gravity and tissue pressure.
Got it.
And then cohesivity is another critical factor. That's how tightly the gel's internal matrix sticks to itself so it doesn't fragment into microscopic pieces once it's actually injected.
And the tan delta. The sources note that for all HA fillers, the tan delta is always less than 1. Why is that?
Tan delta is the ratio of the viscous properties to the elastic properties. By ensuring that tan delta is strictly less than 1, bioengineers are mathematically guaranteeing that the filler is always more elastic, so more jelly-like and structural, than it is viscous or liquid-like.
But how do they actually achieve that at the molecular level? Because, raw hyaluronic acid in our bodies is mostly liquid, right? It turns over really quickly.
It does, yeah. It has a very short half-life naturally.
So how do they convince this natural liquid to act like a permanent structural scaffold?
They build a microscopic 3D matrix using cross-linking agents. Chemicals like BDDE or pigvine. Think of raw hyaluronic acid like millions of individual floating strands of spaghetti.
Okay, spaghetti strands.
Right. If you push on them, they just slide past each other effortlessly. What the BDDE molecules do is act like tiny chemical bridges, binding those individual strands together into a highly complex, tangled three-dimensional web.
Which gives us that perfect G prime and a tan delta under 1.
Exactly.
But this brings up the paradox we mentioned at the start. If you have this heavily cross-linked three-dimensional web that is engineered specifically to hold its shape, how does it physically move through a tiny needle?
What's fascinating here is the precise physics of non-Newtonian shear thinning. This isn't magic. It's mechanical manipulation at the molecular level.
Shear thinning. Okay, explain that.
Well, when the gel is resting in the syringe, those cross-linked polymer chains are all tangled up, maintaining their solid, cohesive structure. But the moment the practitioner presses the plunger, they introduce massive mechanical pressure, which is known as shear stress.
So what actually happens to those chemical bridges under that kind of stress? Do they break?
No, and that's the genius of it. Under immense pressure, the tangled polymer chains are physically forced to align themselves in the exact same direction.
Oh, wow.
Yeah, imagine a chaotic web suddenly streamlining itself parallel to the walls of the needle. This alignment causes the complex viscosity to just plummet. The gel physically thins out, allowing it to flow like a highly viscous liquid.
But then when it leaves the needle,
The instant it exits the needle and that shear stress drops back to zero, those chains immediately retangle. The 3D matrix locks back into place, and it instantly thickens back up to provide that structural lift.
it's literally a shape-shifting liquid that responds to mechanical stress. That is incredible. And because this gel behaves this way, doctors realized they could use it in areas of the body that are highly dynamic and incredibly sensitive to pressure.
Which sets up our exact anatomical destination for this deep dive.
Let's talk about the labial fat pads.
It's a fascinating area of application, truly. The sources highlight that fillers are increasingly being used for labia majora augmentation, primarily to treat fat atrophy.
And I want to make clear to you listening, this isn't just an aesthetic concern. The data points out that fat atrophy in the genital region leads to mucosal atrophy, severe loss of tissue elasticity, and dyspareunia, which is pain during intercourse.
Yeah, it's a major quality of life issue for many women.
So historically, what was the treatment before these fillers?
Historically, autologous fat grafting was really the go-to solution. Taking fat from the thigh or abdomen and physically transferring it to the labia.
That sounds intense.
It is. It's a surgical procedure. It requires downtime, and the major drawback is that autologous fat can resorb really unpredictably. You might inject 10 cc and only retain 3 cc 6 months later.
Which is exactly why these minimally invasive HA fillers are stepping in and taking over. The clinical literature specifically points to products like Deserial Plus, right?
Yes, Deserial's a big one.
It's unique because it is officially registered in Europe specifically for the lipoatrophy of the labia majora. And the studies show it provides immediate volume enhancement, drastically improves tissue hydration because HA naturally attracts water, and the structural lift lasts around 9 months.
But if you are listening to this and wondering why we care so much about the specific rheology for this one area, think about the unique mechanical pressures the labia is subjected to every single day.
It's not like the face.
Not at all. We aren't talking about a cheekbone that remains relatively static. The vulvar region is subjected to constant friction, compression from sitting, tight clothing, and dynamic movement like walking or cycling.
Which means the cohesivity we talked about earlier has to be absolutely dialed in.
It really does. Because if the cohesivity of the gel is too low, the daily mechanical pressure of simply walking could cause the filler matrix to fragment and migrate to distant tissues.
That sounds like a clinical nightmare. Injecting a volumizing gel and having it travel somewhere else entirely in the body.
It's a very valid concern. But this is exactly where the rigorous clinical testing comes in. They use preclinical animal models, specifically rabbit models that were injected with these exact types of highly cohesive, cross-linked HA formulations.
And what did they find?
They were evaluated histologically over time, and the biopsies confirmed that a highly cohesive gel does not migrate to distant organs or lymph nodes.
Oh, that's a relief.
Yeah, the 3D matrix stays exactly where it was placed, promoting local tissue remodeling and even increasing healthy vascularity without triggering a massive foreign body inflammatory response.
Let me form a hypothesis here, though.
Sure, go for it.
If the labia majora requires serious volume restoration to combat atrophy, and it has to withstand all that constant compression from sitting and walking, my instinct says you would need a really hard filler.
Okay, I see where you go.
Like, wouldn't a doctor just reach for the filler with the highest possible G prime, the kind of stiff gel they use to build up jawlines and chin projections?
That is the ultimate balancing act in aesthetic gynecology. To test your hypothesis, no, using a jawline filler would be a terrible mistake there.
Really? Why?
A structural facial filler has a massive G prime because its job is to sit deep on the periosteum and literally mimic human bone. If you place that in the labia, it would feel like a rigid lump. It would be incredibly uncomfortable for the patient.
But on the flip side, you can't just use the watery, low viscosity fillers that they use for like superficial fine lines around the lips or eyes, right? Because they wouldn't offer any volume against the pressure of sitting.
Precisely. It requires a highly specific middle ground. The rheological data shows it needs an adequate G prime, so enough elasticity to physically lift and restore lost volume against gravity and tissue pressure.
But not bone hard.
Right. It must maintain a lower complex viscosity than a structural bone filler so it remains pliable. It has to feel entirely natural and integrate seamlessly into the surrounding mucosal and fat tissues.
So it's a very narrow window of properties.
Yes. Managing that exact balance is why utilizing targeted cross-linked HA, what we call CLHA, is absolutely vital for this indication.
So we have the bioengineering perfected. We have a cohesive, moderately elastic, shape-shifting gel. And we know exactly why the labial fat pads demand that specific profile.
We do.
But we still have to get the gel into the patient safely. And doctors aren't using standard sharp needles for this, are they? The sources emphasize the use of specific cannulas.
That's right. They ditch the sharp needles entirely in favor of cannulas, which are essentially long, blunt-tipped, flexible tubes.
Why are those better?
In areas needing significant volume restoration across a wider anatomical plane, cannulas are just the gold standard. Because they have a blunt tip, they glide through the subdermal tissue rather than slicing through it.
Oh, so less damage.
Exactly. They drastically minimize trauma, reduce bruising, and most importantly, they bypass the risk of vascular occlusion, which is when you accidentally pierce a blood vessel and inject filler directly into the bloodstream.
Yeah, that sounds incredibly dangerous. So the clinical guidelines specify that for labial augmentation, a 22-gauge cannula, usually 40 or 50 millimeters long, is ideal for deep injections and structural support.
Correct.
Or a slightly narrower 25-gauge cannula, also 40 or 50 millimeters, is suited for medium-depth injections in the fat pads.
Those very specific specialized tools, yes.
Here's where it gets really interesting. Let's talk about the physical dimensions of those tools. A 25-gauge cannula is tiny. Its inner diameter is roughly 0.5 millimeter.
It is incredibly narrow.
My instinct says if I take a highly cross-linked chemical matrix, this intricate 3D web of polymer chains held together by those BDDE bonds we talked about, and I force it through a 0.5 millimeter metal tube under immense pressure, the mechanical shear stress is going to just shred those bonds apart.
That would be the logical assumption, yeah.
The structure should be destroyed by the time it reaches the tissue. How does it possibly survive?
It is a brilliant biomechanical question. And it was the exact focus of a critical clinical study evaluating these highly cross-linked HA fillers.
What did this study do?
Researchers wanted to know if passing these advanced gels through 22-gauge and 25-gauge cannulas permanently altered their rheological properties. They took multiple filler brands and used a controlled stress rheometer to measure the exact structural metrics of the gels before they went into the syringe.
And then tested them again after.
Exactly, after they were extruded through the cannula.
Exactly, after they were extruded through the cannulas.
Did the mechanical stress break the polymer bonds? Don't leave me hanging here.
It did not. The data was crystal clear. Statistically, there was zero functional difference in the gel structure before and after it went through the cannula.
Zero difference.
Zero. The researchers specifically measured the G prime, the storage modulus we discussed, and the G double prime, which is the loss modulus. Neither of those metrics changed after being forced through the 22G and 25G cannulas.
That is just mind-blowing to me.
The fillers maintained their desirable, solid-like volumizing behavior completely intact. It gets squeezed through a tube 0.5 millimeter wide, subjected to massive mechanical pressure, and comes out the other end with its structural integrity completely unchanged.
If we connect this to the bigger picture, this clinical study perfectly proves the miracle of the non-Newtonian shear thinning we explored earlier.
Right, because it becomes a liquid temporarily.
Because those polymer chains can temporarily align under stress, the gel gracefully deforms to slide through that tiny 25-gauge cannula without breaking. The covalent chemical bonds of the DDDE cross-linking act as indestructible anchors holding the core matrix together during the journey.
And then it just bounces back.
Once it exits the tip of the cannula and enters the expansive space of the labial fat pad, it immediately relies on those anchors to reassemble its 3D structure.
It survives the journey beautifully. But what about the human driving the vehicle?
The practitioner.
Yeah. We know the cannula doesn't break the gel, but what about the physical effort required by the practitioner? If you're listening to this and wondering why we care about the friction inside a plastic tube, we have to look at the extrusion force.
A hugely important metric.
How much physical effort is actually needed to push this gel through a 22G or 25G cannula, and why is the quality of that force the final critical safety factor for the patient?
Extrusion force is measured in newtons. And while the gel's rheology obviously plays a role, the physical delivery apparatus, meaning the combination of the plastic syringe and the inner friction of the cannula, is actually the most influential contributor to this force.
So how hard do you actually have to push?
According to the clinical evaluations, manufacturers aim for an extrusion force of less than 30 newtons. But in a clinical setting, it should preferably be less than 20 newtons, and most optimally, less than 15 newtons to ensure really smooth injectability.
Okay, less than 15 newtons.
For context, we can look at the in vitro testing done on advanced hydrogels like Mealy. Using specialized rigs that depress the plunger at a constant rate, they recorded extrusion forces as incredibly low as 0.46 newtons to 2.01 newtons.
Wow.
Yeah, depending on whether they used a bolus, point-by-point, or retrotracing injection technique.
I mean, 0.46 newtons is barely any force at all. But the sources emphasize that the raw number isn't actually the most important data point. It's the consistency of the force.
Exactly. When these testing rigs map the force over time, they generate a graph. What bioengineers want to see is a smooth, flat plateau.
Like a perfectly straight line across the graph.
Yes. The RegeneV filler series data specifically highlights this kind of perfect plateau. A consistent extrusion force curve ensures an even, steady flow of the filler out of the cannula tip.
Because if it isn't smooth, the practitioner's basically flying blind. Imagine trying to plunge a sticky, poorly manufactured syringe.
It happens more often than you'd think with inferior products.
You push with 10 newtons of force and nothing happens. You push harder, your hand starts to shake, the pressure builds behind the gel, and then suddenly the internal friction gives way and a massive glob shoots out all at once.
Yeah, the data explicitly warns about this. In one in vitro test on a lesser syringe, irregular pressure spiked nearly 25 newtons before suddenly dropping back down to 7.
That's a massive jump. The clinical literature refers to that as jerking or indentation-like behavior of the plunger.
Right. And in a highly sensitive, highly vascular region like the labia majora, where you are laying down precise threads of volume, that kind of jerking is completely unacceptable. Precision is non-negotiable.
What actually happens to the patient if the extrusion force is uneven like that? I imagine it's not good.
It leads directly to severe complications. An uneven force means the practitioner might accidentally dispense excess hydrogel into one tiny localized spot or place it too shallowly in the mucosal tissue.
Which causes what?
That causes nodules. hard, painful, highly visible lumps of filler. It also causes unnecessary tissue trauma from the sudden expansion, leading to severe bruising and acute pain for the patient during recovery.
Ouch.
A smooth, predictable extrusion force through that 22G or 25G cannula is required so the practitioner can lay down a perfectly even thread or bolus of HA exactly where it belongs without traumatizing the surrounding environment.
Which means the manufacturers have to obsess over the microscopic friction inside the plastic syringe, just as much as they obsess over the rheology of the gel itself.
It's all connected.
It's a completely interconnected system. If the syringe sticks, the world's most perfectly engineered gel is delivered poorly and causes a nodule. If the gel is too viscous, the world's smoothest syringe still requires too much physical force, and the practitioner's hand shakes.
It is a closed biomechanical system. Every variable, from the cross-linking agent to the inner diameter of the cannula to the plastic of the plunger, must work in absolute harmony to ensure patient safety and an optimal aesthetic outcome.
We have covered a massive amount of ground today, zooming all the way in from molecular cross-linking bonds to millimeter-sized cannulas and zooming out to the mechanical pressures of the human body. So what does this all mean?
It's a lot to take in.
Let's synthesize the core findings of this deep dive for you. If a practitioner is going to safely and effectively inject soft HA gels into labial fat pads to treat issues like fat atrophy, a highly specific chain of physics has to occur.
Right.
First, we need a gel engineered with BDDE or PEG-D cross-linking to be volumizing but highly cohesive, providing an adequate G' for lift while remaining soft enough to integrate without migrating.
Second, that specific gel must perfectly execute non-Newtonian shear thinning. Its polymer chains must align under pressure to lower its complex viscosity and flow like a liquid, but immediately retangle into a solid matrix at rest.
Third, because of that exact shear thinning property, the clinical data proves this gel can be pushed through tiny 22-gauge and 25-gauge cannulas without shredding its chemical bonds. Its structural integrity, measured by G' and G double prime, remains entirely unchanged on the other side of the cannula.
And finally, the delivery system itself must be engineered to provide a smooth, consistent extrusion force plateau, optimally well under 15 to 30 newtons.
To prevent that jerking effect.
Exactly. This prevents plunger jerking, ensuring the gel is laid down evenly to prevent nodules, tissue trauma, and patient pain in a highly sensitive area.
It is, top to bottom, an absolute symphony of bioengineering.
It really is. But this raises an important question. Despite all of this highly standardized, perfectly quantifiable physics, the newtons, the tan-delta ratios, the precise cannula gauges, the actual clinical execution remains highly individualized.
What do you mean by that?
Well, the speed of the practitioner's push, the angle of the cannula entry, whether they prefer a retrotracing technique or a targeted point-by-point bolus, it all varies wildly by the doctor.
Oh, I see.
It proves that while aesthetic medicine is built on profound, uncompromising science, the actual practice remains an art form that relies heavily on the human practitioner's tactile feedback and anatomical expertise.
The laboratory can provide the perfect, mathematically flawless paint, but the human practitioner still has to paint the masterpiece.
That's a great way to put it.
Which leaves you with one final thought to ponder today. We started by talking about the impossibility of building a bridge out of a liquid.
Right.
But if bioengineers can manipulate the physics of a fluid so precisely that it temporarily forgets its own thickness, squeezes through a half-millimeter tube, and then flawlessly rebuilds its 3D solid structure inside the complex biomechanics of the human body, what other highly localized, time-release medical treatments might this shape-shifting gel technology unlock in the future?
The possibilities are endless.
If we can program a fluid to do this for aesthetic volumization and tissue hydration, what could we program it to do for targeted drug delivery, localized oncology treatments, or internal tissue repair?
The structural engineering of the human body is just getting started, and these gels are really only the first blueprints.
Something to think about the next time you hold a syringe. Thanks for taking this deep dive with us.